Good morning, everybody. On behalf of the Ceylon College of Physicians, welcome to the Young Physicians Forum, which is being streamed live from the Clinmark Auditorium of the National Hospital. The Young Physicians Forum showcases the talents in the clinical sense of young physicians who are generally senior registrars in the different fields of medicine. So we have two speakers today. First, Dr. M.A.A. Shami, who is a senior registrar in nephrology from the National Hospital, Kandy, who's going to speak on the heart when the kidneys are broken. And after that, we have Dr. Harsha Disanayaka, who is a senior registrar in endocrinology of the National Hospital of Sri Lanka, who will speak on shifting paradigm in diabetes care, control, remission, and cure. So to start with, I'm pleased to invite Dr. M.A.A. Shami to make the first presentation on the heart where the kidneys are broken.
Good morning to all of you, and thank you very much for the Ceylon College of Physicians for giving me this opportunity. So today I will be talking about mainly the heart diseases from a nephrological point of view. Uh, in the case of chronic kidney disease, where and how the heart diseases differ and how they develop and what are the causes for that. As you can see, uh, this is a renal biopsy, which is incidentally shaped as a heart, which probably affirms the close connection between the kidneys and the heart. If we take the epidemiology, the heart diseases are far more common in the population of chronic kidney disease. Some diseases are as common as almost twice, as we see here. Congestive cardiac failure is around twice more or more than twice as common in chronic kidney disease population. I'd be going through briefly all these diseases in where and how they differ in a patient with advancing chronic kidney disease. To start with, the coronary heart disease is the one of the most common problem we see in the chronic kidney disease population. So much so is many consider it to be an equivalent for coronary heart disease. The CKD is considered an equivalent to the coronary heart disease. The reason for this being a lot of traditional common risk factors which are both common to the both populations. The patients who develop chronic kidney disease also have, and the patients who develop the coronary heart disease both have these risk factors in common most of the time. For example, hypertension, smoking, diabetes, dyslipidemia, and a lot more. But there are several risk factors that are non-traditional and that are almost unique to the CKD population. And one of them being the retention of uremic toxins, which worsens with the progression of CKD. And I will talk about them more in a while. And also anemia, which is multifactorial in the chronic kidney disease patient, causes coronary ischemia. And there are the metabolic changes which see in the CKD patient with elevated cytokines and the poor nutritional state, which augments the atherosclerosis. Also, in the abnormalities in the bone and mineral metabolism, which causes increased calcification of the vessels, which also adds to the atherosclerosis and coronary heart disease. As we see in this diagram, in a normal patient with coronary heart disease, the calcification is only seen in the atherosclerotic plaques. But in the patients with CKD, due to many reasons, the intramuscular calcification is seen, which causes reduced pliability of the vessels and also increased ischemia. And the causes, as we see, can be all of these listed. And there are several other unique pathophysiological mechanisms which are found in the CKD population. One being the carbamylation of the LDL molecules, which is the most profound factor in driving atherosclerosis in the patients who smoke. But if we see from a different point of view, smoking also causes a lot of unwanted chemicals in the blood, and uremia also causes the same. So it is as bad as smoking. The carbamylation of LDL is commonly seen in the uremia population and also in smokers. And several other chemicals which accumulate in the blood, for example, ADMA, and many others inhibit nitric oxide activity. So this causes ultimately leads to vasoconstriction and ischemia, and also increase in the calcium phosphate products, which will cause increased intravascular calcification and worsen, as I told before. In broad strokes, the management revolves around the modification of the risk factors, and statin use in the CKD population is in a bit of controversy, but it is advised if the patient, in pre-dialytic patients, to start on statins, as it is a very high risk state. Also in the post-dialysis patients, if the patients are not on statin, not to start newly, but if the patients are on statin, to leave it while the patients are being dialyzed. And we have to control the hypertension, and as well as starting on the aspirin use is there is not much of a the trials have these findings have been from the subgroup analysis, but the aspirin is also advised in patients if the patients have other risk factors like previous coronary heart disease or any other significant risk factors. If the calculated score is very high, then we can start on aspirin. But we have seen in the chronic kidney disease population, there is a poor prognosis with interventions like PCIs and intravascular interventions. The reason being probably because of the vascular calcifications and vascular changes that happen in the chronic kidney disease. In this diagram, picture, we can see the significant vascular calcification, the calcification of the aortic arch and the aorta as showed by the arrows. The hypertension is very common in the CKD population. Almost more than 85% of the patients will develop hypertension in one time or the other in their CKD states. And the pathophysiology is it is multiple. Hypertension can be a causative agent for the development of CKD, and also in the end stage, the patients develop sodium retention and fluid retention, which causes hypertension. And because of the patients with chronic kidney disease usually are in renin-aldosterone and angiotensin-aldosterone system is hyperactive in them. So that causes angiotensin-mediated vasoconstriction and hypertension. Also, the afferent arterioles, the sympathetic system usually, because of the uremic toxins and also the sympathetic drive which is trying to dilate the afferent arterioles to supply blood to the kidneys, there occurs a generalized sympathetic overdrive, which also causes high blood pressure. And as we also know that the CKD produces hyperparathyroidism, which increases the intracellular calcium levels in the smooth muscles, which causes it to go into a tonic state, which produces vasoconstriction and high blood pressure. And we usually give erythropoietin to control anemia in the CKD population. Erythropoietin reduces the carbon dioxide mediated vasodilatation, which causes increased blood pressure. And as we noted before, the arterial stiffness increases in CKD because of the calcification. Also, CKD population are known to have the nighttime dipping of blood pressure. Normally in the normal population would have around 15 millimeter mercury of reduction in the blood pressure early morning, but which is not seen in the CKD population, probably because of the uremic toxins and increased sympathetic overdrive. So the management of hypertension is not much different from the normal population with the lifestyle modifications like salt restriction, weight reduction. And antihypertensives can be are also as in normal population, but we will have to pay special concern to the hyperkalemia, because ACE inhibitors and ARBs can cause hyperkalemia, and also the use of diuretics in very end stage renal failure patients might not be useful. It is advised that if the eGFR is less than 30, the thiazide diuretics alone would give a very minimal benefit. But at that time, if we start on a loop diuretic, then the thiazide diuretics can be helpful with that. And also, to not only give the doses of the blood pressure antihypertensive medication in the morning, so we can spread out, giving a night dose also, which would help in that non-dipping of the nighttime blood pressures. And as we know, the final in the if it becomes uncontrollable, we can always go into dialysis to control the fluid and pressure overload. As we see here in the CKD patient, the yellow line shows the blood pressure of a CKD patient. We see in the early mornings it almost stays the same, but in normal population there is a dipping. The congestive cardiac failure, the heart failure mostly in the CKD population is a diastolic dysfunction, but there are, I would talk mostly about systolic dysfunction in these patients, because the pathophysiology of it is it's multiple, and it is helped by these features. One is, as I talked before, the ischemia, coronary heart disease is more prevalent in the CKD patient. And also because of the hypertension, there is a significant pressure overload, and because of the fluid retention, there is a significant volume overload. And also, we most of the time we create fistulas to access blood for hemodialysis, which causes a high output circulation and which could cause high output cardiac failures. And also anemia will support in this high output situation. And there is myocardial fibrosis noted in the patients with CKD, which I will be discussing in a moment. And there is also an entity called hemodialysis-induced myocardial stunning, which is post-dialysis. We can see wall motion defects without any blocks in the coronary arteries. This is thought to be because of significant fluid shifts during the dialysis and the pressure difference. This is just to illustrate when we have this a high output fistulas, the patient has a high volume circulating through the heart, which causes predisposes to a dilated heart. So the management is mainly we have to manage the fluid overload. In early CKD, we can use diuretics. In late CKD, that is mostly dialysis. And the hypertension should be managed. We can use beta blockers because there is prognostic benefit. And also, we have to manage the coronary heart disease and the anemia. Because of this, with the development of this heart failure, patients are more prone to get any arrhythmias, which will even worsen the cardiac failure. So we have to manage that. I would like to talk a bit about this entity called uremic cardiomyopathy, which is actually a name, which is a term which is coined in the pre-dialytic era, where they found patients with severe uremia without dialysis developing cardiac dysfunction. But in fact, it is a multifactorial entity which develops due to all the things I have mentioned before. So the causes are being that all the risk causes for the heart failure is contributing to that. And also there are several factors which in the uremic population, mainly the hyperphosphatemia causes a phosphatotoxicity to the myocardium, which goes and changes the genetic makeup to a bone forming features. So the calcification and fibrosis intramuscularly increases in the heart. And the FGF23, fibroblast growth factor 23, is also does the same thing, but the problem is it increases in the blood early in the CKD, far before the phosphatemia picks up. And this molecule, this has been recently diagnosed, the alpha-klotho, which is a soluble receptor for the FGF23, which reduces, mitigates the effect of FGF23. So we find that increases in FGF23 and reduction in alpha-klotho levels, which causes cardiomyopathy. Also, this FGF23 is increased. This is a adverse effect of increasing phosphate levels in the blood. So as we see, the cardiomyopathy is a final common pathway of all those features, like the hypertension, the other features of left ventricular hypertrophy. All those with these uremic features finally cause the entity called uremic cardiomyopathy. I'd like to discuss a bit about the arrhythmias. Atrial fibrillation is the most common arrhythmia found in CKD, but ventricular arrhythmias are also very common. The causes for that being the cardiomyopathy, as I discussed above, which causes and also the ischemia and ischemic foci can cause arrhythmogenic foci. We know that electrolyte imbalances are commonly noted in the CKD population, mainly in the advanced CKD population. When they are getting dialyzed, there is wild variation of electrolytes, mainly potassium, which causes acts as an arrhythmogenic, which is arrhythmogenic. And also rapid fluid shift during dialysis causes increased sympathetic activity and tachycardia, and that can also cause arrhythmias. And some drugs, like mainly the ACE inhibitors, ARBs, which can cause elevated potassium levels, and sometimes digoxin, which easily becomes toxic in the population, in the CKD population, because of the potassium differences. And most of these patients, we send home, some of them, we send home with a catheter in situ, probably permanent catheters or temporary catheters for some time. They act as an nidus for the development of arrhythmias. And the management of arrhythmias, in ventricular arrhythmias mainly, are to optimize all those risk factors I mentioned above. And we can optimize the dialysis with change of an increase of frequency and ultrafiltration. And also if it is not smooth and if the electrolyte imbalances are too much, we can even opt for peritoneal dialysis, which will give a smoother transition of electrolytes. For atrial fibrillation, anticoagulation is advised in EGF if the EGFR is more than 30. In the population where the warfarin, it can be used as in normal population. And the apixaban is noted to have the least risk profile for bleeding. As we see here, while dialysis, the potassium levels vary widely. Here we can see around 4 milli equivalents of potassium change during the 4 hours of dialysis. But we tend to think that the patients, end-stage renal failure patients, are more resistant to hyperkalemia, but they are. But they are not very resistant to variations in potassium. It is same as the normal population. So this is detrimental for them. And the valvular heart disease, there is a very high prevalence. As noted in this slide, the aortic valve calcification is around almost 1/4 to 1/2 of the patients in end-stage renal failure on dialysis has that, and mitral annular calcifications are also very common. The reasons being the mineral bone disorder in the CKD causing increased calcification. Also, infective endocarditis, which has many risk factors in the CKD population, as I will discuss in a moment, which will cause valvular heart disease. And the high output states, which causes increased shear stress, will cause increased calcification and valvular breakdown. And some diseases like polycystic kidney disease and all has a cardiac component like mitral valve prolapse. So we can see in this diagram, first shows an aortic valve and the second a mitral valve, both in CKD patient and has significant calcifications. Infective endocarditis is in fact one of the most common diseases we treat in our hospitals in the nephrology wards. It has a very high mortality. And the causes being that we are recurrently introducing bacteria into their systems by pricking for hemodialysis. And lot of patients we send home with an indwelling catheter, which the tip is most of the time in the heart. So it is a direct access to the bugs to the heart. And uremia predisposes to significant immunosuppression, and a lot of patients have also undergone a previous transplant and are also on immunosuppressive drugs. And as I mentioned above, the patients also have valvular heart diseases, which predispose to infective endocarditis. And we see a lot of MRSA, and worldwide it is the most common in the end-stage renal failure and advanced CKD patients. And we treat with most common used antibiotics are vancomycin and gentamicin. In this picture, we can see a permanent catheter in situ when we discharge these patients. It is easy access to the bacterium to the heart. I would also touch on before ending about uremic pericarditis. It is thought to be due to the aggregation of uremic toxins, which causes increased expression of interleukins and tumor necrosis factor, which causes pericardial inflammation, which can cause pericarditis and pericardial effusion. Luckily, the hemodialysis relieves the symptoms in more than 75% of the patients. Before ending, I would just talk about the cardiorenal syndromes. It is not a different entity. It's not a different disease or an entity, and it is just a aggregation of symptoms. And what interests us today is cardiorenal syndrome type 3 and type 4, which is an abrupt, in type 3, an acute renal failure causing an acute deterioration of cardiac function. That is usually that is pulmonary edema. And the causes are being, as I mentioned above, all the causes can be lead to this. And the type 4 is actually what I have mentioned above, that is chronic kidney disease predisposing to heart failure. All the causes I discussed above can be a cause for this. So I would like to end with the same picture I showed you before. The kidney biopsy looks like a heart. Thank you very much.
Thank you very much, Dr. Shami. I think we have some time for questions.
Just one question. Now, when you looked at what you presented, one of the common groups of drugs that came out are the ACE inhibitors and the ARBs. Now, they will have a detrimental effect on the kidney as well, especially when the renal failure is advanced. How do you manage it? Because you need to manage the cardiac problem as well as the renal problem. So, what's a practical way of doing it?
Yeah. It is usually ACE inhibitors in most of the causes that causes renal failure, like diabetes. We see most of the patients are because of diabetes. ACE inhibitors play an important role. And also in proteinuric kidney disease patients, ACE inhibitors causes significant reduction in proteinuria, and also it slows the progression of kidney disease. But the problem is in end-stage renal failure patients. When you sometimes we receive patients like they are in end stage, and we need to work up them quickly, and we don't have much time. So at that moment, if we start on ACE inhibitors, their GFR drops even further, and we run out to a place where we need to start on acute hemodialysis with an acute catheter, which is more detrimental for them. In that situation, weighing the risks and benefits, we tend not to start on ACE inhibitors in very end-stage renal failure patients in that kind of a situation. But most of the others, when we follow up from an earlier stage, we start on ACE inhibitors or ARBs. And also, just after the patient has been started on hemodialysis, and we can prescribe them without any problem, monitoring the potassium levels.
Shami, now when you are speaking about the statins, there was some reluctance in starting statins to CKD patients. Why is that, and what guidelines do you refer to?
Yeah. With regards to the statins, yes, statins normally KDIGO guidelines suggest that the statins can be started in the pre-dialytic patients, and just after dialysis, it is advised to, if the patients are on statins, to leave the statin dose as such, but not to start newly. Because if the patients are not on statin, in dialysis patients not to start new doses of statin.
What is the reason behind that?
Because I'm not sure, really sure.
Any other questions?
This is a question sent for the Zoom chat box. Is there any association with dialysis and cardiac function?
Yes, there is it depends on the one thing. It depends on the mode of dialysis. In patients who have significant cardiac involvement, we tend to start them. We advise to start them on peritoneal dialysis because it is more cardiac friendly, and the fluid shifts and electrolyte shifts happen over a long period of time, and also it is the variation of the fluid and electrolyte balance is not much high. But when we start on dialysis, there can be, as I mentioned, there can be many reasons that go into affect the heart cardiac functions. Mainly the patients before dialysis, they are fluid overloaded. Usually they are fluid overloaded and hypertensive, and hyperkalemic. And average potassium level goes around 7, even in centers where you provide 3 dialysis per week. And after dialysis, it all varies. And this variation over time causes significant cardiac involvement and cardiac failure.
Okay. I think we are up for time, but Dr. Shami, thank you very much for that excellent presentation. It was a great pleasure having you with us today. I have a small certificate of appreciation. We move on to the next presentation, which is by Dr. Harsha Dissanayake, which is on shifting paradigm in diabetes care, control, remission, and cure. Over to you, Dr. Harsha.
Good afternoon to all of you, and thank you, Chairperson, sir. Let me also thank the Ceylon College of Physicians for giving me this opportunity. So what I intend to do in the coming 20-25 minutes is to sensitize you towards an emerging paradigm or a new concept in the management of diabetes. Let me begin by reminding ourselves about a common day-to-day scenario that we all have encountered. A 40-year-old man is newly diagnosed to have diabetes. He comes to you with increased HbA1c and fasting plasma glucose. He's asymptomatic and the history is otherwise unremarkable. He is obese by our standards and also has a high normal blood pressure. My question is, what am I going to tell this patient? What will you tell this patient? Should we say that you have diabetes and you're going to live with that for the rest of your life? Should I suggest that let's try dietary and lifestyle modifications first before starting pharmacological agents? Or should we directly offer him antidiabetic drugs? Or should I start with insulin to begin with? I'm sure you would have your own answers for this, maybe based on current guidelines. Let us keep that in the back of our mind and move forward. In the first part of my talk, what I would do is to recapitulate how the understanding of pathogenesis of type 2 diabetes has evolved over time and how that has changed or shaped the way we manage it. And then I'll focus on some data about the shift in paradigm trying to remit or cure diabetes, and finally discuss whether this is a realistic goal. Our understanding and our knowledge on type 2 diabetes and its natural history is largely shaped or molded by what the UKPDS trial taught us. In people with type 2 diabetes, there is a gradual, progressive, irreversible, and inexorable decline in beta cell function, and this is probably due to beta cell death, is what it taught. There have been many explanations why this happens, why the hyperglycemia occurs, and this was led by the triumvirate concept proposed by Di Fronzo, where the key highlights were insulin, hyposecretion, and increased insulin resistance in the liver and peripheral tissue. Over next 2-3 decades, this has expanded into ominous octet and further into egregious 11 and dirty dozen and all that. And that has also been the focus upon which the therapeutic targets and therapeutic agents have been developed. And this has also molded the way the targets we keep in treating diabetes, whether it is glucocentric approach about several decades ago into cardiovascular risk reduction, and finally nowadays the focus on cardiorenal centric approach where antidiabetic agents with cardiorenal benefits beyond its glucose lowering efficacy are given priority. But underlying all this, there is one fundamental agreement or consensus within our minds, and that is that the beta cells will continue to die. The disease will continue to progress. What we do is react to that. We'll try to replace whatever the deficient insulin action, and we'll also try to mitigate the complications that arise as a result. Is this the best way to handle diabetes? A different angle to the question or a different perspective was first explored by a group of researchers as long as 3.5 decades ago from today, where they studied 10 individuals who had type 2 diabetes, who had failed to control on sulfonylurea therapy, and they put them on intensive insulin therapy for 3 months. And what they observed was, interestingly, the insulin requirement declined by nearly 40%. And more than that, about half of the participants managed to come out of all antidiabetic therapies and remained in a possible remission for at least 3 months. This was the first evidence to say that beta cells are non-functional, but not all of them are dead. They are in a recoverable state. These findings were replicated in several other small-scale studies using intensive insulin treatment strategies, and they showed that the beta cell function can be increased by about 13%, and even the insulin sensitivity can be improved by about 43%. And looking at those studies, at 3 months from the intervention, about 60 to 70% would achieve remission of diabetes. And at 1 year, about 40 to 50% will still remain in remission. What all this data tells us is that hyperglycemia itself will suppress the beta cell function, the so-called glucotoxicity. Is it the only factor that keeps beta cells in a suppressed state? In another interesting in vitro experiment where beta cells were incubated with fatty acids, these researchers showed that when the beta cells take up fatty acids and store as triglycerides, along with the rise in triglycerides, their insulin secretory capacity would also decline. And interestingly, when it is reversed, when the fat from the beta cells are removed, they will regain the insulin secretory capacity. So, not all the non-functioning beta cells are dead and gone. Some are in a reversible state of non-function or dysfunction. And this is principally mediated by glucotoxicity and lipotoxicity, and it is reversible. How about insulin resistance? There is ample data to say that when the liver accumulates fat, its insulin sensitivity declines. And the key determinant is the intrahepatic diacyl glycerol concentration, which is a metabolite of triacyl glycerol. Is the reverse true? If we remove the fat, will it restore the insulin sensitivity? Of course, this was shown in this study where they studied about 12 individuals who had diabetes, offered them a very calorie-restricted diet, and they showed that after the intervention, their insulin sensitivity will increase close to non-diabetic controls, and their liver fat content will decrease close to non-diabetic controls. Based on all this data and information, a twin cycle hypothesis was proposed to explain the pathogenesis of type 2 diabetes. Let me take you through this. So, most studies have shown that despite the aggressive control strategies, the muscle insulin resistance is very difficult to get down. Perhaps it's genetically determined. Now, in a genetically predisposed individual, if he is exposed to excessive positive energy balance over a long time, This will accumulate in the liver as fat, and that will also increase the lipogenesis within the hepatocytes, which also means that liver will export more fat out of it to other ectopic sites. And islet cells is one such site where they accumulate fat, and this will lead to de-differentiation of beta cells. This in turn will result in reduced insulin response, particularly to a glucose load taken orally, and this will raise the postprandial blood glucose. When this happens, the rest of the functioning beta cells will try to compensate by increasing its basal insulin secretion. Now, this high basal insulin secretion will further promote the adipogenesis or fat synthesis within the liver, pushing it into a vicious cycle. And the rising glucose will impart glucotoxicity and further de-differentiate the beta cells, driving another vicious cycle in the pancreatic beta cells. So these two vicious cycles will operate in tandem and will grind forward until such stage where beta cells are non-functional enough to cause overt hyperglycemia, where we diagnose diabetes. Now, why does beta cells de-differentiate in the face of metabolic stress? What is thought is that what is shown in orange is a differentiated beta cell that is producing insulin. They fare poorly when they are faced with metabolic stress compared to its precursors or alpha cells. So in the face of metabolic stress, that is glucotoxicity and lipotoxicity, these beta cells will de-differentiate into a precursor beta cell which is not secreting insulin, or it might or even de-differentiate into an alpha cell which is less susceptible to metabolic stress. Now, over years, if the metabolic stress continues, these cells will eventually undergo apoptosis and will not be recoverable. In the de-differentiated stage, if we can re-differentiate them, that is where the hope for remission or cure of diabetes exists. Removing glucotoxicity and lipotoxicity on liver and pancreas can restore beta cell dysfunction. The obvious next question is, can pharmacotherapy do this? The therapeutic agents do this? Can they reactivate the non-functional beta cells? This was studied recently in the RISE consortium, where they offered different potent glucose lowering strategies like glargine, insulin, metformin, liraglutide in different combinations. They treated for 1 year and then took off treatment for 3 months and tried to see what happened. Importantly or interestingly, the BMI declined, the HbA1c declined, even came into non-diabetic range in some, but soon after it was discontinued, they rapidly returned to where they started. Same was observed for beta cell function. It soon returned to what it was in the baseline once the treatment was discontinued. Currently, existing pharmacotherapies can improve beta cell function, but effects would last only as long as the treatment is continued. We need a better solution. This is where bariatric surgery and the data from multiple cohort studies as well as randomized control trials come in, where there is an encouraging number. It's 60% of individuals with type 2 diabetes who undergo bariatric surgery or metabolic surgery will achieve remission of diabetes. Is that the answer for the question? Obviously, we know for multiple reasons this is not something practical or feasible, and these are those reasons. But if we closely look at what really happens after bariatric surgery, I would have imagined that they lose weight so their insulin resistance would go down, and that's how they would remit diabetes. But if we actually look at the metabolic parameters, this is time after bariatric surgery, and you can see that within a week, the fasting blood glucose will normalize. Within a week, the hyperinsulinemia will start to come down. And within a week, the insulin sensitivity virtually normalizes and then stabilizes. Mind you, this is far before any meaningful weight loss is achieved. So what it all says is that bariatric surgery can effectively achieve remission, and probably the key mechanism is acute calorie restriction, because after a surgery, the patient would receive about 600, 700, 800 calories a day. And this is thought to be the reason why such a fast remission of diabetes can be achieved. Can we replicate this in non-bariatric surgery settings? That is where the counterpoint study becomes important to appreciate. This study examined the effect of hypocaloric diet of about 600 to 700 kilocalories a day in 11 participants, and they showed the findings very similar to what the bariatric surgery showed. Within a week, fasting blood glucose normalizes, hepatic glucose output reduces, and the hepatic fat content reduces, all in parallel. They also looked at the beta cell function. The first graph on your left shows the normal controls beta cell response, where there is a first phase and then a delayed second phase of beta cell response. In diabetic individuals, the first phase is totally blunted, totally absent, and the second phase is blunted. And when they go through a calorie restricted diet, the first phase insulin response is restored and the second phase is amplified. And importantly, the return of first phase of insulin response closely paralleled the reduction in pancreatic fat content. What all this tells us is that an acute energy deficit will reduce liver fat, will increase the hepatic insulin sensitivity, and reduce the fasting plasma glucose. And at the same time, it will also remove the pancreatic fat accumulation and will restore the biphasic insulin response, thereby leading to remission of diabetes. So, without surgery, can we achieve this by lifestyle interventions? Look Ahead was a large study that was primarily designed to study the effect of intensive lifestyle intervention with a calorie restriction to 1,200 to 1,800 a day, about 5,000 individuals. They wanted to study its effect on cardiovascular outcomes. The study was negative for its primary outcome over a 5-year follow-up. However, interestingly, they showed that at 1 year, with the intensive lifestyle modification, about 12% achieved diabetes remission. And even at 4 years, close to 8% remained in diabetes remission. Well, there was an argument that this might have been due to inadequate calorie restriction. And then the counterbalance study was designed to give a very low calorie diet. Individuals with type 2 diabetes, 30 of them were offered 700 calorie restricted diet a day over 2 months. And then the food was gradually reintroduced and they went into a weight maintenance phase, followed up for 6 months. Nearly half of them achieved remission. Those who achieved remission, this graph in black shows how their HbA1c and the fasting plasma glucose change, while the other half showed only a little response, if at all. So VLCD seems promising, but is it a pragmatic solution? Can we ask our patients to take just 700 kilocalories a day? It is as good as having just a one decent sized burger and that's it for the day. This is what was examined in the DIRECT trial, which was a pragmatic study done entirely in the UK, recruited recently diagnosed individuals with type 2 diabetes, in the sense within 6 years. They were obese, and they were randomized to go through a very low calorie diet, followed by a gradual food reintroduction and then a weight maintenance. And this was compared against a standard diabetes care. They showed that at the end of 1 year, 45% were in diabetes remission. At 2 years, it came down, but still 35% were in remission. Greater the weight loss they achieved during the very low calorie diet phase, greater the chance of them achieving diabetes remission. These findings were replicated subsequently in the Diadem-1 study, which was done in Qatar, where they showed nearly 60% of individuals were in some form of remission at the end of 1 year. Do we have any data from Asia? This is a cohort study from Thailand, where they studied 21 patients with type 2 diabetes, went through the same very low calorie diet, and at 3 months, 80% were in diabetes remission. This is data from Barbados, from the Caribbean. Again, a similar intervention. Non-diabetic level glycemia was achieved in 60% of the individuals, and those who lost more than 10 kilos in weight were more likely to achieve remission. So VLCD seems to induce diabetes remission, and that is feasible in primary care setting because, as I said, both Diadem and DIRECT were done in primary care setting, of course in a different healthcare setup compared to that of ours. There's another obvious problem that we need to acknowledge, and that is not all will respond. If you look at the data from Counterbalance, where they studied 30 individuals, let's look at this closely. Both the responders as well as non-responders lost weight to a same degree. The amount of liver fat they had at the end of the intervention was similar in both responders as well as non-responders. And it was pretty much the same when it comes to pancreatic fat. But what was remarkable is responders restored their first phase insulin secretion to a much higher degree than the non-responders. And this was replicated in the direct study. Weight loss, liver fat reduction, pancreatic fat reduction, all were similar in responders as well as non-responders. However, recovery of first phase of beta cell insulin secretion was the key determinant or the key difference. Can we understand it based on this diagram? Now, in the face of metabolic stress, beta cells will de-differentiate. They are non-functional but can be recovered. And we know that to restore the first phase of insulin response, we need a reasonable number of beta cells to do that. So if the cells are in this recoverable stage, then there is a chance to reverse them back to functional stage. But if they have progressed to death, there is no chance of recurrence. So individuals who had enough number of dysfunctional cells which can be recovered were more likely to achieve remission, despite of achieving the same level of weight loss, same fat reduction in liver and pancreas. If the cells are dead and gone, this is not going to be feasible. Higher the number of reversible dysfunctional beta cells, greater the chance of remission. The other obvious question is, or the problem is, relapse. Even with bariatric surgery, over years, a proportion of individuals who achieve remission will relapse. And this is closely related to the degree of body weight regained after the initial weight loss. So what is important there is to keep the metabolic stress away, prevent weight regain, and keep glucotoxicity and lipotoxicity away. This needs a lot of commitment from the patient himself, as well as his close family and surroundings, as well as from healthcare providers and healthcare systems perspective. Is there an easy way out? Can we induce redifferentiation of beta cells by pharmacological means? This is an area of extensive research. The entire transcriptomes of beta cells in their different stages of maturation have been mapped, and strategies have been developed to target and deliver a therapeutic agent to the de-differentiated beta cells. But how to manipulate the transcriptome and how to reverse and regain the beta cell function and cause redifferentiation is still a question unanswered, but an area of intensive research. That brings me to the end of my presentation, and let me summarize and say that beta cell de-differentiation is central to the pathogenesis of type 2 diabetes. Their redifferentiation is the key to achieve diabetes remission. This can be done by a significantly calorie-restricted diet or by metabolic surgery. Its sustainability, of course, is still challenging. Whether pharmacotherapy can be developed to achieve this task for us remains a question to be answered in the coming years and decades. Going back to where we started, if at this point you can identify something wrong and something right about each of these statements, I think I have achieved my objective. Thank you very much for attentive listening. I would be happy to take any questions.
Thank you very much, Harsha, for that excellent presentation. I think we have time for questions.
Harsha, it's an excellent lecture. Now we are talking about this obese diabetics. Now, does this apply to the lean diabetics as well? Do we go for the weight reduction there as well?
Thank you for raising that question. So the question is whether this can be done in those who are not obese. If you look at the data on VLCD, all studies recruited participants with a BMI of at least 27. So this has not been studied in those who are lean. That is actually one of the limitations, because some of our patients might have already lost weight by the time they come to us because of diabetes itself. So there is no data to say that this will work in such individuals.
Thank you, Harsha. That was very interesting. Any data from Sri Lanka? Have we tried something similar? Do you know whether it will work for our population? As you said, it's a different setting. So
yeah. So we actually do not have our own published data. But as a fact, I'm aware that some patients in some settings may be put on this, and there are some promising results coming out. There are several challenges that we have to appreciate when we try to apply this strategy to our setting. One is, as Sir raised out, it is limited to only those who are obese. The second question is, if we look at the participants in studies in other countries, on average they weighed about 100 kilograms. And their average calorie requirements were in the range of 2000, 2100 a day. So coming to 800 from 2100 is a significant reduction. But if we look at our build and our calorie requirement in an average female, probably that's about 1500. So if you try to achieve the same percentage reduction, that's going to be impractical. And we do not know whether bringing it down to 800 would still have the same effect. So there are a lot of unanswered questions, and probably it's an area worthwhile to explore.
Yeah, there are about 3 questions. Coming to the Zoom chat box, can we apply moderate exercise to restore beta cell function by burning fats?
Right. So moderate exercise does improve beta cell function. There is data to say that. But I'm not exactly sure whether it is being asked in the context of a very low calorie diet. If that is the case, it is not advisable to start both very low calorie diet and exercise of any intensity together, because once a calorie intake is restricted to 750, 800, it's very difficult for an individual to tolerate any exercise. Another problem of introducing exercise early is that would lead to compensatory overeating, which is going to disrupt the very low calorie diet. That's why they say start with very low calorie diet, achieve a weight loss, then with the gradual reintroduction of food, start a gradual escalating program of exercise.
And again, they're asking, what is the place for using empty calorie foods for restoring beta cell function?
Right. Empty calorie food?
Yes. What is the place for using empty calorie foods
Right.
for restoring beta cell function?
Right. So I honestly have not come across any data about this, any research publications on this. But I suppose if it is used to induce satiety without giving calorie, as long as the total calorie intake for the day is restricted to whatever the target, that should work. But actually, I'm not aware of any published data on that.
The last question is, when a diabetic patient gets remission, do we stop insulin therapy?
So diabetes remission is defined as a state of non-diabetic glycemia without the need for any anti-diabetic medication, which includes insulin. So there is debate over the diagnostic criteria as well. ADA, EASD proposed that they should be off treatment for 6 months to say that the patient is in remission, whereas most of these studies labeled remission if they are in non-diabetic glycemia for 2 months. So the answer to that question is yes, they should be off all glucose-lowering therapies to call one is in remission. Yes, sir.
Age of patients in our setting are actually obese, diabetic patients. Have you any idea, like obese or overweight?
Right.
Where
So
they may be?
I'm not exactly sure about the type 2 diabetes Sri Lankans, what percentage are obese or overweight. But in general, I know the last prevalence data on diabetes from a reasonably national-wide came in Sri Lanka Diabetes and Cardiovascular Study in 2006, and that was overall about 11%. But in some recent small studies in Colombo, this is even about 25%. Obesity prevalence was in a similar range, about 10-12% in at least in urban settings. But I'm not exactly sure among diabetic individuals how many were obese.
Okay. So, Prasad.
Some comments. So actually, we had been practicing this remission for a while, and quite a significant number of patients, particularly if they really commit themselves, can remit. And two questions that you all raised. That is, one thing is weight loss. sometimes, as Harsha said, some patients have already lost quite a lot of. So even maintenance of that lost weight sometimes might be sufficient for those people. The other thing is definitely we need to do research, because we need to identify the correct phenotype. Particularly some of these young, so lean diabetic people might have these conditions like LADA and so on. So you need to really pick up the correct phenotype of type 2 to make it really, achievable and correct.
So in other words, the answer to the question, Devadiya honda karanna puluwanda is now going to have a positive answer, and yes, in the future. Thank you very much, Harsha. That was a brilliant presentation, and thank you to both of the speakers. Harsha, I have a small certificate to present to you. That brings us to the close of the first part. That's the Young Physicians Forum. There are a few people to thank, both of the speakers, Harsha and Dr. Shami, for their brilliant presentations. The judges, Professor Chandani Manigatunga and Dr. Upul Disanayak, for spending their valuable time with us this morning. I'd also like to thank Priyamali Jayasekara, who is in charge of all these sessions, for her commitment and for organizing them brilliantly. I would like to thank the staff of the ClinMark for their support as always, and the audiovisual team for their excellent work. Very well coordinated and very well done. And finally, to the audience, all of you, for being here, and those who are joining us online, and also to CIPLA, who has sponsored the session. That's the second part. May I now invite, we move on to the second part of the day, the day's academic program, which is the college lecture. I would like to invite my colleague, Dr. Senaka Bandusena, who is the president of the Association of Sri Lankan Neurologists. So from this year onwards, all of these college lectures are joint sessions between the Ceylon College of Physicians and a sister college or society or association in the country. And this month is with the neurologists. I would like to invite Dr. Bandusena to introduce the speaker, the college lecturer.
Thank you, Senak, and I also thank CC for actually inviting me to co-chair this session. It's a very important one, and I think we move on from two very excellent Young Physician Forum lectures, and we move on to the college lecture. And today's college lecture will be delivered by Dr. Kumarangi Vithanage, MBBS, MD, MRCP. She's a consultant neurologist and senior lecturer at the Faculty of Medicine, University of Colombo, and she's a very active council member of the Association of Sri Lankan Neurologists, and has been alive via this year. So over to you, Kumarangi.
Thank you, sir, for those kind words of introduction. And let me thank CCP at the outset for giving me this opportunity in collaboration with SN to talk to you on muscle disease, a clinical approach. So when we say muscle, you know that there are three types of muscles in the body. But when we say muscle disease, we are focusing on the skeletal muscle. Okay, thank you. Right. So when we say muscle disease, we are focusing on the structural or the functional abnormality of skeletal muscle. So if you remember the innervation of the skeletal muscle and this concept of motor unit, skeletal muscle are innervated by the motor neurons. So the cell body lies in the spinal cord, and the motor unit is comprised of a single motor neuron and all its innervating fibers. So as a result, the muscle dysfunction can occur due to defects in any of these structures. It could be the cell body of the motor neuron, the axon, or due to defects at the level of the neuromuscular junction. But when we say muscle disease, we are focusing on the skeletal muscle proper. So in my lecture, I would basically be concentrating on the skeletal muscles, primarily on the skeletal muscles itself, but at times I would be touching upon the neuromuscular junction disorders as well. So clinically, we can classify broadly into muscle disorders, into hereditary varieties and acquired. So by and large, if you consider myopathies in neurological presentation, it's relatively rare. And out of the two, hereditary, it's extremely rare compared with the acquired. So hereditary myopathies could be congenital, myotonias and channelopathies, muscular dystrophies, certain metabolic myopathies, and mitochondrial myopathies. So there are a lot of tiny subsets into each of these entities, which I'm not going to list here. Then the relatively common variety, the acquired, could be drug-induced, endocrine, inflammatory, myopathies associated with systemic diseases like hypothyroidism, and toxic myopathies. So when we're approaching a patient with muscle weakness or features of muscle disease, our aim would be to elaborate on the history and examination and try and fit the patient into one of these entities. So to make it easier, I would be taking you along 6 salient points in the history and examination, which would help you to probably diagnose them clinically. So the first feature, which negative and or positive symptoms and signs does this patient demonstrate? So the negative would be the weakness, fatigue, exercise intolerance, and muscle atrophy. Then the positive would be the myalgias, cramps, contractures, stiffness, or myotonia. So in myotonia, they would present as stiffness, and rarely myoglobinuria. So out of all these features, the commonest would be weakness. Then if you think of the conditions where diffuse myalgia is a presentation, it could be endocrine, inflammatory, and in infectious etiologies. Then muscle stiffness, or you would elicit myotonia on examination in these patients. The causes, they are not common, but the causes would be periodic paralysis, hypothyroid myopathy, and myotonic disorders. Then myoglobinuria, along with weakness, I said it's not so common, but it can rarely present in certain metabolic myopathies. Right, so the second salient feature in the history is the temporal evolution, how the disease has progressed over time. So for that, first would be to consider the age of onset of symptoms. Now for this, if you classify them as presenting at birth, presenting in childhood, and presenting in adulthood, again, there would be a very exhaustive list, which is virtually impossible to remember. So in generally, as the name implies, the congenital myopathies would present at birth. And acquired varieties are commoner in adulthood and in childhood. Some of these, like dermatomyositis, would present in childhood as well as in adulthood. Acquired in general are common in adulthood. So if you think of the hereditary varieties, this diagram is worth remembering. Although it's not common, if you come across even at a rare instance, this would help to give a clue to the diagnosis. So the Duchenne and Becker's present at the first decade generally. And these limb girdles, facioscapulohumerals present and in second, third decades, whereas the oculopharyngeal is generally considered as the disease of adulthood. So they present in around fourth or fifth decade. So that's about the age of onset of symptoms. Then about the evolution and duration of the disease, certain conditions can present with a constant weakness, like in dystrophies and inflammatory myopathies. Some could be episodic, as in periodic paralysis. Then how about the progression of the disease? Is it acute or subacute progression, as in inflammatory myopathies, polymyositis, dermatomyositis, or whether the progression is chronic, very slow, very subtle, which is the case in most of the dystrophies, muscular dystrophies. Or else, as in congenital myopathies, it could be static, virtually non-progressive. So these we can pick up from the history upon elaborative questioning. Right. So the third salient feature in the history and examination is about the weakness. So I said weakness is the commonest presentation. Now, this you should know depending on the presentation, even though the patients directly don't admit, should know what and where to look for. For example, in facial muscle involvement, they would not be able to smile properly, and whistling, drinking from a straw would be difficult. Then ocular involvement will have diplopia, ptosis. Bulb involvement, speech and swallowing difficulties, choking spells, aspirations. Then in neck muscle involvement, head control would be a problem. They find it difficult to lift the neck up when from the pillow when they get up in the morning. Truncal muscle involvement will result in abnormal postures like scoliosis, lordotic posture with a protuberant belly. Shoulder girdle involvement will result in winging scapula and would find it difficult to reach for objects at a higher level. Forearm and hand involvement, distal muscle involvement, will result in defective fine motor involvement, making a fist-like. Then pelvic girdle involvement would result in an abnormal waddling gait. I'll show you some of these gaits a bit later. And so they find it, with the pelvic girdle involvement, they find it difficult to get up from a seated or a squatting position. So there would be positive Gower's sign and Trendelenburg test being positive. Also, there could be distal lower limb involvement, leg or the foot involvement. So you have to get them to walk on toes or walk on heels. Depending on whether it's the anterior or the posterior compartment muscles that are involved, there would be positive signs. Then, of course, the use of accessory respiratory muscles in the case of a respiratory muscle involvement. So these needs to be actively looked for. So then the weakness, you know, this has to be graded along the MRC scale. So not only the weakness, there could even be atrophy. So now in most of these muscle disorders, the presentation is a proximal muscle weakness. So there would be atrophy in the involving the proximal muscles, where you will not be able to differentiate much beyond that unless you really look for. But in certain conditions, like in limb girdle muscular dystrophy, facioscapulohumeral, there would be selected targeted groups of muscles which have undergone atrophy in particular. Then in inclusion body myositis, there will be finger flexors, forearm flexors, and the quadriceps wasting. So there would be targeted certain muscle groups which have undergone atrophy. So not only weakness, not only atrophy, there could even be hypertrophy. So like in Duchenne and Becker's, there would be calf muscle. You call it pseudo-hypertrophy because it's not really the muscle which has undergone hypertrophy, but it's due to the replacement with connective tissue and fat. But in certain other limb girdle muscular dystrophies, in myotonia congenita, and in certain systemic diseases like amyloidosis, sarcoidosis, there would be hypertrophy of the muscles. Right. So the fourth salient feature in the history is to try and identify whether anything has triggered or precipitated this weakness. For example, if it's a monophasic presentation, it could be that the patient have consumed some illicit drug like cocaine, amphetamine kind of. Then prescription medication like steroids, statins, they can also result in weakness, muscle weakness. Then history of weakness, pain, or myoglobinuria provoked by exercise. Not common, but this you can see in glycogen storage disorders. A similar presentation with fever and a fasting stage you see in lipid metabolism disorders like carnitine palmitoyl transferase deficiency. Then whether these events precipitated by exercise or high carbohydrate meal, you would wonder whether it's hypokalemic periodic paralysis. Myotonia congenita, weakness can precipitate with the exposure of cold. So these patients might present with difficulty in swallowing when they try to swallow ice cream. So stiffness precipitated by cold exposure. Right. So the fifth feature in the history is to see whether there is any family history involved. So for this, if you just ask the patient whether there is any family history of muscle disease, they might say no, because as you could see, there could be many forms of inheritance that could result in a number of muscle disorders. Where the presentation, so the phenotype would be so very much heterogeneous, and the progression, particularly if it had been very chronic and subtle or even non-progressive, people might not really realize them having a weakness. So it's important to ask about the activities of daily living, the functional status, and the use of mobility devices among family members. So that's a family history. Then the last feature in the history and examination is to see whether there are any associated systemic manifestations. So in the presence of muscle weakness, if there is cataract, diabetes, perhaps intellectual impairment, you would wonder whether it's myotonic dystrophy. Retinal changes, optic atrophy, multiple lipomas, whether it's mitochondrial myopathy. Then dermatomyositis, you know, will have a whole spectrum of cutaneous manifestations. Of course, one would always remember that these muscle disorders can involve the heart as well. So these have to be actively questioned and looked for. So if we look at the conditions that commonly give rise to respiratory insufficiency, congenital myopathies and storage disorders and metabolic myopathies can perhaps present with respiratory insufficiency. But by and large, most of these myopathies would result in respiratory insufficiency at some stage, where the initial manifestation would be nocturnal hypoventilation, because they generally don't manifest with symptoms unless until the FVC drops beyond 50%. So you need to remember that, because this would help in planning out their management. So as I said before, there could also be the cardiac involvement by means of congestive cardiac failure or arrhythmias. Right. So these are the 6 salient features in the history and examination that would help you to arrive at a presumptive clinical diagnosis when a patient presents with muscle weakness or features of muscle disease. So with this, let's see, let's look into this common presentation of muscle weakness in a broader sense with the approach of pattern recognition. So the first pattern, so I'll take you along 10 patterns. So the first pattern is the limb girdle pattern, which is the symmetrical proximal limb involvement. So as I said before, this is the commonest presentation of muscle disease, and just the isolated proximal muscle involvement might not be very helpful in further diagnosing or the definitive diagnosis of the muscle disorder. So in that instance, you have to look for other features as well. So let me show some pictures here. So in the first picture, it's a case of Duchenne muscular dystrophy. We see the proximal muscle weakness. Along with that, there is pseudohypertrophy of the calves. So combining the features would help you arrive at a diagnosis. Then this picture, this gentleman is trying to abduct his shoulders and he fails in that. So there is proximal muscle weakness, and the reason for him is this. So it's not from the same patient, but the reason is this. So he had dermatomyositis. So you would see in dermatomyositis, if you look for the heliotrope rash, Schall sign, the Gottron's plaques, and some of them will have mechanics hands. So the pattern 1 is a limb girdle pattern. The pattern 2 is a distal muscle involvement. Now, although the proximal involvement is the commonest variety, some can rarely present with the distal muscle weakness as well. Now, this should be differentiated from neuropathies, because that would be the common presentation with the distal involvement. But in most of these are hereditary. So this is a case of Miyoshi, which is a dysferlinopathy. You would see the distal muscle wasting, and they have weakness. The third pattern is where there is a proximal arm and distal leg involvement. So this is also known as a scapulo-peroneal pattern. So they have the proximal arm and the distal leg involvement. So this is a case of facial scapulohumeral dystrophy, which is commonly asymmetrical in this entity. So here you would see the winging scapula, asymmetrical scapulae, and here you would see from the anterior aspect a hump, which we normally don't see in abduction of the arms. So this is due to poor fixation of the scapula with the parascapular muscles, and you call that appearance winging scapula. And this is also a picture of facial scapulohumeral dystrophy, where this lady is trying to smile, but she cannot because of facial muscle weakness. Then the fourth pattern is where there is distal arm and proximal leg involvement. Now this you would see in inclusion body myositis and myotonic dystrophy. The age of onset can be helpful in differentiating the two. So you see the quadriceps wasting here, and here the patient is trying to make a fist and the patient cannot. So there is significant wasting and weakness of the finger flexors. So this is pattern 4. Pattern 5 is where there is ocular involvement along with proximal muscle involvement. Now this you see in myasthenia and in various other conditions. So the hallmark of differentiating myasthenia from others would be fatigability. So in this you see there is asymmetrical ptosis along with ophthalmoplegia. So this is a picture of ocular myasthenia. And here in these two, the ptosis is relatively symmetrical. So this is a case of oculopharyngeal muscular dystrophy, and here this is due to a myotonic dystrophy. So the age of presentation differentiates the two, and of course you have certain other features like the temporal balding and the hatchet face, which are the other features of myotonic dystrophy. Then the muscle disease pattern 6 is where there is neck muscle weakness. So this you can see in myasthenia, and also it could be due to isolated neck extensor myopathy. Muscle disease pattern 7 is where there is predominant bulbar involvement, probably with a proximal symmetrical limb involvement. Again, you see this in myasthenia and in oculopharyngeal. So the common entity would be here myasthenia. Then the pattern 8 is where there would be weakness along with myoglobinuria. I said it's not so common, but if it presents, one will have to think of metabolic storage disorders. Pattern 9 is where there is episodic weakness, delayed or unrelated to exercise. This could be due to periodic paralysis. Then the last pattern is where they present with stiffness, inability to relax when the muscle is contracted. You would elicit myotonia in these patients. So I'll show you 2 videos here. So this is percussion myotonia. Upon contraction, there is delayed relaxation. So you would see in the tongue as well as in the thenar eminence. Right, so that's about for the 10 patterns of muscle weakness. I'll show you 2 videos in the muscle gait. So you see here, there is lordotic posture in this child with proximal, and there is somewhat distal weakness also. So there is lordotic posture with the proximal belly, and there is high stepping gait. And in this gentleman, also there is a proximal pelvic girdle involvement resulting in a waddling gait. Right. So that's for all the clinical points, the history and examination, but we would need a whole battery of other investigations at times to arrive at a confirmatory diagnosis. So CPK being the most vital of the laboratory, the biochemical investigations, then EMG, repetitive nerve stimulation, the electrodiagnostic tests, muscle histology plays a pivotal role here. Neuroimaging at the experts' hands would also yield a lot of valuable information, particularly with inflammatory myopathy and molecular genetics. In fact, it's replacing the use of histology now, particularly with the hereditary muscle disorders. Right. So I've got two quick case scenarios for you. So this is a 30-year-old female presenting with proximal weakness and bulbar involvement with fatigability over a period of 2 years. So she had facial muscle involvement with the respiratory muscle involvement in the absence of ptosis or diplopia. Acetylcholine receptor antibodies were negative. So in the absence of time, I'll move on with the explanation myself. So this is a case of seronegative myasthenia. So this is a case of, so MuSK antibody became positive. So that is, so in that variety, the ocular manifestations would be minimal. Then there's another case where a 65-year-old woman presents with a 7-year progressive history of dysphagia and weakness with mild proximal weakness, and she gave a history of similar symptoms in the family. So again, you have the proximal muscle along with the bulbar involvement with a positive family history in the absence of fatigability would point you towards a diagnosis of oculopharyngeal muscular dystrophy, can be confirmed by the neurogenetics. So, ladies and gentlemen, in conclusion, I was trying to highlight ways of making a diagnosis when patients present with muscle feature suggestive of muscle disorders, because the presentation, the phenotype of muscle disorders can be very much heterogeneous. So, you need to dig into history and examination, followed by other investigations whenever appropriate. Thank you.
Thank you very much, Kumarangi, for that excellent overview of how you should approach a patient with a suspected muscle disorder. I think it's a very challenging area. I think even as a neurologist, we always struggle, but you made it very clear if you are systematic and set about in the proper way, you can pin it down to a particular diagnosis. Now it's open for, we can take a few questions.
Just to make a comment, the beauty of a good presentation is that it simplifies things for even a person who is not an expert in the field to understand. So thank you very much. It was very, very informative.
If I may ask a question, I think when it comes to muscle disorders, I think most disorders don't have a specific treatment, but I think it's very important not to miss the treatable entities. Can you tell us a little bit what are the conditions that are treatable in a certain sense, and then when you would suspect?
Neuromuscular junction disorders, commonly the myasthenia, has definitive treatment. So, it's a steroids, immunomodulatory therapy with steroids, IVIG, plasmapheresis are the commonly used modes of therapy for myasthenia. So, that has a definitive treatment. And also the inflammatory myopathies, apart from inclusion body myositis, dermatomyositis, polymyositis can also be treated with steroids and immunomodulatory therapy. And also, if you think like in episodic weaknesses, where you can identify a trigger, avoidance of a trigger is a way of treating. And also in the case of statin-induced myopathies, either stopping the treatment completely or prolonging the duration, like giving every other day therapy or changing the statin or reducing the dose. So those are the options for statin-induced myopathies.
Just a little question. There will be the difficult part will be differentiating some of these from neurological conditions. Isn't that the case? Neurological means things which involve the nerve itself.
Neuropathies.
Yes, neuropathies and central things. Are there any diagnostic sort of dilemmas there?
Yeah. So the spinal cord related, the way to differentiate that would be the spinal cord related etiologies. Would be features of upper motor neuron disease. So yeah, the muscle, the manifestations are all lower motor. As I mentioned in the distal myopathies, that is an area which is rather tricky, where when the patients present with distal muscle weakness, commonly it's due to a neuropathy rather than a myopathy. So in that case, there would be features like pain, a radiating pain, and there would be sensory signs on examination, and the reflexes. So now, as a general rule, we say that in muscle disorders, reflexes are preserved. But with the advanced diseases, with the atrophy of the muscle, you may not be able to elicit the reflexes. So in early stages, the reflexes would be intact in muscle diseases and would be absent in neuropathies.
I think when it comes to clinical exams, also for those who are hoping to do the MD part 2 clinical exam, I think muscle disorders are very important. We had a mock exam the other day, and actually we did have a patient. I don't think any of the candidates got the diagnosis. So I think it happened to be a fascioscapulohumeral dystrophy. And I think if they did listen to Kumarangi's lecture, they would have noticed the asymmetrical scapular winging and the facial weakness, which was overlooked. So I think, thank you, Kumarangi, for that excellent lecture. It was very comprehensive, and I think we learned a lot from it. Thank you. And we have a small token of appreciation. Prof. Senekul.
So again, that brings us to the close of another college lecture and a series of excellent talks today. I would like to thank Dr. Kumarangi Vitanage for a brilliant presentation, and my co-chair and the Association of Sri Lankan Neurologists for joining us to conduct this joint session. This whole month is dedicated to neurology, really. And Dr. Kishara Gunaratna, I don't think he's here, but he's the coordinator who links the CCP with the Association of Neurologists. And Dr. Premali Jayasekar is our organizer for this whole series for the year. I'd like to thank the audiovisual team again and the staff of ClinMark for their excellent work and their support. And finally, the sponsor for this particular college lecture is George Stewart Health. So thank you very much. And many thanks to the audience for being with us today. Thank you and have a good day.